Hi everyone, and welcome to our presentation. We are Group 50 and together we are Helena, Elma and Harry, and we will be speaking to you about type 1 diabetes. We will be discussing with you today the pathophysiology, pharmacological interventions and nursing management of a patient with type 1 diabetes. My name is Helena and today I'll be presenting you with the case study. Alistair is a 37-year-old male who has been admitted to the emergency ward with severe hypoglycemia. Alistair's presenting symptoms to the ward includes an increased work of breathing, a dry mouth, dehydration, vomiting and frequent urine output. Upon his admission into the ward at 6:45 p.m, Alistair had told staff that he had not had any insulin for the day. Upon taking some further observations of the patient, Alistair's respiratory rate was at 38, his blood pressure reading was 110/50, his oxygen saturation levels were at 97%, he had a temperature of 37.7 degrees, he had a high blood sugar level reading of 9.1 millimoles per litre, his pH levels were at 7.2, his bicarb at 12, and his ketones measured at 3.6 millimoles per litre. There is a family history of type 1 diabetes in the family, with Alistair's mother Sarah also diagnosed with the illness. Alistair has been diagnosed with type 1 diabetes since he was 8 years old. His wife Lisa has informed staff that Alistair poorly manages his condition at home and most nights forgets to self-administer his insulin.
Type 1 diabetes mellitus is a result of the autoimmune destruction of beta cells in the islets of Langerhans and is thought to be a result of gene and environment interaction. Between 10 and 13% of individuals with newly diagnosed type 1 diabetes have a parental sibling also affected by it. Diagnosis peaks at the age of 12 but can be present in infancy. We know type 1 diabetes is a result of severe or absolute lack of insulin caused by loss of beta cells, and at presentation some insulin may still be produced. However, this will only decrease with time as beta cells are lost. Destruction of these islet cells is thought to be related to genetic susceptibility, autoimmunity, and environmental factors. As a result, it is a slowly progressive autoimmune T-cell mediated disease that destroys beta cells of the pancreas. Autoantibodies that fight against these pancreatic cells are often detected long before symptoms become apparent. Before hypoglycemia occurs, 80 to 90% of insulin-secreting beta cells of the islets of Langerhans must be destroyed. This is so what is left of the remaining cells can elevate the production of insulin to compensate for the destroyed beta cells. However, with few beta cells remaining, insulin production is no longer adequate. In addition to the decline in insulin production, the production of amylin, another beta cell hormone produced in conjunction with insulin, is also depleted. Amylin's critical role, amongst others, is to suppress glucagon release from the alpha cells. Therefore, disequilibrium of hormones produced by the islets of Langerhans occurs. And when both beta cells function and alpha cell function are not considered normal due to a lack of insulin and a relative excess of glucagon, this then leads to hypoglycemia. Hypoglycemia is a condition in which an excessive amount of glucose is circulated in the blood plasma. Consequently, if the patient's blood sugar is not within the recommended normal ranges, and in Mortier's case his BSL is 9.1 millimoles per litre, therefore exceeding the normal range, it is more often than not a telltale sign that the patient may be hypoglycemic. Many people do not experience the symptoms of hypoglycemia until their blood sugar is extremely high. In addition to hypoglycemia, proteins and fats break down also due to lack of insulin, resulting in weight loss and increased production of ketone bodies, which lead to ketoacidotic states and death if insulin deficiency is not corrected. Ketone bodies are acids that disturb the acid-base balance of the body when they accumulate in excessive amounts, which result in diabetic ketoacidosis, DKA. Signs include abdominal pain, vomiting, hyperventilation, fruity breath, which we would expect to see with Kussmaul's breathing, also evident in Mortier, and if left untreated, an altered state of consciousness, coma and death.
As described by Billis and Donnelly 2010, diabetic ketoacidosis is a state of severe, uncontrolled diabetes characterized by hypoglycemia and metabolic acidosis in the face of absolute insulin deficiency. Alistair is already presenting with signs and symptoms of diabetic ketoacidosis.
Initial clinical manifestations of type 1 diabetes are generally acute, with presentations of polyphagia, increased hunger, polyuria, increased urine production, and polydipsia, increased thirst. Polyphagia occurs because glucose and lipids do not enter in the cells in sufficient amounts, and therefore cells are deprived of nutrients, which in turn stimulates increased food intake. Polyuria occurs due to the kidney's inability to manage the high amount of glucose in the bloodstream. Glucose filters freely at the nephron. However, in non-diabetic people, all glucose is returned to the blood by reabsorption. But in diabetics, the hypoglycemia means that there is a much higher amount of glucose in the blood that is filtered, that cannot be fully reabsorbed, as the transport maximum is exceeded. Subsequently, some of the glucose appears in the urine. Furthermore, the osmotic effect of glucose in the urine draws water into the urine from the bloodstream, increasing the production of urine. The water being lost from the body in the urine leads to dehydration, which triggers increased thirst in an attempt to rehydrate the cells. Dehydration can lead to low blood volume and hypertension. Weight loss is another manifestation because fluid loss is in osmotic diuresis and a loss of body tissues as fats and proteins are used for energy.
While providing care to our patient who will be using pharmacological interventions and will be focusing on lowering blood sugar level, keeping our patient hydrated and preventing nausea and vomiting. Patients with the type 1 diabetes must take insulin to prevent ketoacidosis and stay alive, since the pancreas is no longer able to produce insulin. The binding of insulin to the insulin receptor, a tyrosine kinase receptor, results in the variety of action, including lowering blood glucose levels. In case of Alistair motor, we will be more focusing on fast-acting insulin. Examples of long-acting insulins are insulin glargine and detamine. Trade names are Lantus and Levemir, which can either be subcut or IV infusion. However, they are contradicted individuals with the history systematic allergic reaction to pork. Some of the adverse reactions associated with this drug is metabolic issues such as hypokemia, hypoglycemia, swelling or infection at the site of injection or IV site. Therefore, it is very important to carefully monitor this medication and the patient before and after administration. Periodically monitoring glycosylated hemoglobin levels, regular assessment for the monitoring of any signs of a hypoglycemia such as sweating, shaking, high heart rate, hunger, confusion, fruit-like breath odor, frequent urination and thirst, and the monitoring the level of potassium and magnesium. Hyperglycemia leads to osmotic diuresis, loss of electrolytes and dehydration, which can exacerbate the metabolic acidosis. Hence, it is important to keep our patient hydrated, and normal saline is the best pharmacological intervention to meet this goal for quality care. However, some of the contradictions are hypertension and pulmonary edema. Therefore, it is very important to regularly monitor blood pressure levels and respiratory for any signs of deterioration such as heart failure and sodium retention. Some of the adverse reactions which may occur because of the solution or the technique of administration include febrile response, infection at the site of injection, venous thrombosis or phlebitis extending from the site of injection, extravasation and hypervolemia. In the case of any adverse reaction, stop the infusion and evaluate the patient. In case of Alistair motor, it is important for us to manage nausea and vomiting, and antiemetic drugs are used in managing nausea and vomiting, which reduce the hyperactivity of vomiting reflex. Prochlorperazine is usually used in clinical setting. Some contradictions are not to use in patients with history of alcohol, spinal and epidural anesthetics. Some adverse reactions are dizziness or psychotic symptoms, tachycardia, peripheral edema, hypoglycemia, urine retention. Therefore, it is very important to consider the route of administration, either orally or intramuscularly. At the end, it is very important for us as the nurses to regularly assess all vital signs for any signs of a high blood pressure, heart rate, and doing an ECG to monitor cardiac rhythm.
Quite often, a forgotten management of patients in the ward is providing patient education. and as nurses, it's our responsibility that we provide Alistair with all the necessary information on his condition, including ways he can prevent future developments of hypoglycemia and avoid future hospitalizations. As Alistair has been poorly managing his condition at home, the method of education can be extremely beneficial for the patient. Firstly, as nurses, we will need to provide the patient with a detailed and easy to understand explanation of the pathophysiology of his condition. This will include providing all the potential major risks and complications of type 1 diabetes, his present diagnosis of hypoglycemia, and its potential long-term complications. As well as educating the patient, it is also important to educate the carers of the patient if they do have one. In the case of Alistair, his carer is his wife Lisa. It is our duty to ensure we provide her with the same information as provided to the patient, as well as providing her with any contacts to external supports if required. Carers of patients with type 1 diabetes mellitus are encouraged to support self-management of insulin administration and self-monitoring of blood glucose and ketones by the patient. Some specific information that is important to provide regarding self-administration and monitoring include: 1. The frequency at which Alistair should be testing his blood glucose levels. Adults such as Alistair with type 1 diabetes are recommended to test their blood glucose levels at least 4 times a day. However, in certain circumstances where Alistair may find himself ill or frequently participating in sports, it is recommended that blood glucose levels be checked up to at least 10 times a day, as a way to self-evaluate whether there needs to be any adjustments made to the insulin levels administered. 2. Regarding self-administration and monitoring, Alistair should also be provided details on the blood glucose levels that he should be aiming for. At a fasting glucose level, a normal range is between 5 to 7 millimoles per litre for adults. For pre-meal glucose levels, a normal range is between 4 to 7 millimoles per litre for adults. And for post-meal glucose levels, a normal range is between 5 to 9 millimoles per litre for adults. It should be explained to the patient that maintaining blood glucose levels between these ranges, although can be quite difficult and exhausting at times, that it's okay for levels to slightly fluctuate around these ranges, as certain lifestyle factors such as exercise, a night out, and eating dinner out can affect these levels, as long as a patient is aware of any symptoms that may occur and is able to manage adverse outcomes should they happen. 3. It is also beneficial for him to know the blood glucose levels that are concerning and may require immediate help or hospitalization. A blood glucose level when fasting that falls below 4 millimoles per litre can be seen as an extreme risk or already present sign of hypoglycemia. A blood glucose level when fasting greater than 7 millimoles per litre can be seen as an extreme risk or already present sign of hyperglycemia. The inclusion of multidisciplinary teams is also an effective approach to managing and educating patients. It would be beneficial to refer the patient to a dietitian to educate the patient and provide structured plans that include foods that are highly recommended for patients with type 1 diabetes mellitus. Dietitians are able to provide guides on healthy lifestyle choices that can be beneficial for the patient and help to motivate and encourage them to make healthier choices. A dietitian will also be able to increase Alistair's nutritional knowledge that he can incorporate into his daily life, including how to identify labels on foods, provide relevant recipes, and what to purchase when dining out. An exercise physiotherapist would also be another recommended referral for Alistair, as they would be able to work with the patient to create a suited exercise plan that can be incorporated into his current day-to-day activities. Through promoting a healthier lifestyle between the dietitian, physiotherapist, the patient, and their carer, it can allow for an improved quality of life for the patient. Nursing management of prevalent ulcers in type 1 diabetes mellitus patients. As nurses, we will need to closely monitor the skin of patients such as Alistair with type 1 diabetes. Poorly controlled and managed type 1 diabetes can lead to the development of painful blisters, ulcers, and dystrophy of limbs. Such developments can become as a result of poorly managed insulin administration, as the condition is not cared for effectively. As nurses, we will need to examine Alistair's skin daily primarily around his extremities, to check for any lesions, ulcerations, rashes, or blisters. In hypoglycemic patients such as Alistair, it is quite common for ulcers to appear on feet and extremities such as hands and fingers. Ways to manage and prevent occurrences of ulcerations include incorporating the use of hydrogels, appropriate positioning of the patient whilst in the hospital bed, and promoting physical movement throughout hospital stay, and appropriate foot care such as maintenance of toenails and bunions if present. Also, a referral and collaboration with a podiatrist would also be ideal.
The ultimate goal for the patient is to live a life as healthy and normal as possible. This can sometimes be difficult to achieve as type 1 diabetes requires a significant amount of self-care by the individual as well as regular monitoring from the doctor and other healthcare professionals. As an initial step, the nurse should conduct and monitor an ECG to detect any arrhythmias that could indicate abnormal potassium levels. Vital signs including blood pressure, heart rate, respiratory rate, arterial blood gases, and a mental status examination are to be assessed and documented every hour, as changes in urological status can indicate cerebral edema. Fluid status and urine output are to be closely monitored due to high risk of kidney failure and secondary to severe dehydration. A urinalysis is also important, as it is often a first step to identify any large amounts of ketones or glucose present in the urine, which indicates hypoglycemia. Our main focus is correcting the hypoglycemia, dehydration, and electrolyte loss. Rehydration. It is important to protect the airways and to nurse at a 30-degree angle during rehydration to reduce the risk of cerebral edema. Rehydration is important for maintaining tissue perfusion and enhanced glucose removal by the kidneys. Patients might need up to 6 to 10 liters of IV fluid to replace the fluid losses caused by polyuria, hyperventilation, diarrhea, and vomiting. Initially, sodium chloride solution is administered at a rapid rate, usually 0.5 to 1 liter per hour for 2 to 3 hours. However, rapid fluid replacement can cause cerebral edema, especially in children and older people, and has a high, largely preventable mortality rate. Hypertonic solution may be used if hypertension, hyponatremia, or heart failure is present. After the first 3 hours, half normal saline is used for continued rehydration if the blood pressure is stable and the sodium level is not low. Moderate to high rates of infusion may be required for several more hours. Fluid volume status is monitored by measuring vital signs, possible changes in blood pressure and heart rate, assessing respiratory function and breath sounds, and monitoring intake and output. Initial urine output will lag behind the IV fluid replacement until dehydration corrects, replacing electrolyte losses. When replacing electrolyte losses, the major electrolyte of concern during treatment of hypoglycemia is potassium. Although the initial plasma concentration of potassium may be low, normal or even high, potassium depletion from body stores is significant because of the potassium shift from the intracellular to extracellular space. In addition, the serum potassium usually falls as the acidosis resolves and potassium re-enters the cells. Therefore, potassium must be monitored frequently. Insulin administration enhances the movement of potassium from the extracellular fluid into the cells. Cautious but timely potassium replacement is vital to avoid arrhythmias that can occur with hypokalemia. Up to 40 millimoles per hour by IV infusion may be needed for several hours. Potassium must be infused even if the plasma potassium level is normal. Laboratory measurement of potassium is measured frequently during the first 8 hours of treatment. Reversing acidosis. Acidosis is reversed with fluid replacement and insulin. Insulin inhibits fat breakdown, prevents ketosis, and reduces hypoglycemia. Insulin is usually infused IV at a slow, continuous rate. Blood glucose must be measured 1 to 2 hourly until the blood glucose returns to normal. Only rapid or short-acting insulin is administered IV. The nurse must convert hourly rates of insulin infused to IV drip rates. Insulin must be infused continuously until subcutaneous insulin administration resumes. Any interruption to insulin delivery results in the reaccumulation of ketone bodies and worsening acidosis. Even if blood glucose levels are normal, insulin should not be stopped. Blood glucose levels usually return to normal before acidosis corrects. Therefore, IV insulin may be continued for 12 to 24 hours until the serum bicarbonate levels reach 15 to 18 millimoles and the individual can eat and drink normally.
National Safety and Quality Health Services Standards were developed by the Australian Commission on Safety and Quality in Healthcare. The primary aims of the NSQHS standards are to protect the public from any harm and to improve the quality of a health service provision. They provide a quality insurance mechanism that tests whether relevant systems are in place to ensure minimum standards of safety and quality are met, and a quality improvement mechanism that allows health services to realize any developmental goals. In case of Alistair Motor, medication safety and partnering with customers are the most important NSQHS standards. It is very important to safely administer medication to our patient to improve safety and quality of medication use, which involves full knowledge about medication before giving to the patient, such as any side effects, contradictions, and reason behind giving that medication, following the 7 rights of a drug administration safety and appropriate documentation, as well as checking all DD drugs by 2 RNs. In addition to that, leaders of a health service organization implement systems to support partnering with patient carers and other consumers to improve the safety and quality of care. In our case study, it is important to have partnership with Alistair Motor because after discharge, he will be self-administrating insulin and taking care of his blood sugar levels. Hence, it is important to involve him in all aspects of his care and doing as much patient education as much we can. Also, partnering with health professionals such as dietitian for the consultation of diabetic diet as well as an occupational therapist.